morning, everyone. Today we will be speaking on the prognostic factors in head, neck, and oral squamous cell carcinoma. I will be speaking on extranodal extension and perineural imaging, while my colleague Dr. Ketan will be speaking on Gauss pattern of imaging and depth of imaging. So to begin with, extranodal extension is also known as extracapsular spread or extracapsular extension, was first described by Willis. Extranodal extension indicates the excess aggressiveness of the tumor, which increases the possibility of tumor cells entering the bloodstream, which raises the risk of distant metastasis. But one exception might be HPV-related oropharyngeal cancers, for which the clinical impact is yet to be established. So we all know that pathological extranodal extension is considered the gold standard for diagnosis. However, but the prerequisite for it is that surgical treatment is required. So there are many subsites like your oropharynx and your laryngopharynx where radiotherapy is the primary treatment. So in these cases, pre-treatment evaluation of extranodal extension is important. So we all know about these two landmark trials, the Bonnier and the Cooper. So the Bonnier is the URTC trial and the RTOG Cooper. So both studies compared the addition of concomitant chemoradiation, in which high doses of cisplatin was used on three weekly cycles, and they compared it to radiation alone in patients with high risk cancers of oral cavity, oropharynx, larynx, and hypopharynx. So they found out that extracapsular extension and microscopically involved positive margins were the two main risk factors for which addition of chemotherapy showed a benefit. So on the basis of it, the AJCC subsequently in 2017 added the extracapsular spread or extranodal extension as staging. So in any clinical extranodal extension is classified as N3D, while in pathological you have, if there are multiple nodes with any of the nodes showing extracapsular spread or any lymph node with more than 3 centimeters with extracapsular spread is N3P, and if the size is less and only one node is showing extracapsular spread, it's considered an N2E. But we all know that addition of chemotherapy to the radiation has multiple side effects. Hence, the further role of extranodal extension needs to be studied to avoid these side effects. So what are the problems currently? So there is lack of consistent definitions, what term to be used, the widely accepted criteria for and classification system for both pathological and radiological extranodal extensions. Then what is minor, what is major extranodal extension, and HPV positive related. It's a wide topic, but I am sure I will discuss. So there are three increments you can say of extranodal extension. So initially it is pathological where any minor even ENE can be picked up. Then it comes radiological. So when we do the imaging, if the extranodal extension is little more, then it can be picked up on radiology. And finally clinical, which is apparent to all of us during examination. So what is pathological extranodal extension? It is extension of the tumor cells outside the lymph node capsule into the perinodal soft tissue during histopathological examination. So there is a spectrum of pathological extranodal extension. So when it is there is no extension when the tumor is confined to the lymph node. When the tumor just extends past the capsule by less than 2 millimeters, when it disturbs the capsule, it is known as minor extranodal extension. More than 2 millimeters, and when it comes out of the capsule, it is major. And finally, when there is another term called as soft tissue metastasis, when there is a separate nodal mets are separate from the lymph node. So, what is the important now prognostic significance of minor pathological ENE? So, it is still debatable and not widely proven. So, there are multiple studies like Carter et al., D. Carvalho, Clark. All these showed that the macroscopic, that is more than 2 millimeters pathological ENE, increase the recurrence and worsen the recurrence-free survival. But they found that the microscopic, that is less than 2 millimeters, had no impact. Even studies like Briesman et al., which studied the influence of extracapsular nodal spread on prognosis, then Mamick et al., all these studies, they did a ROC curve analysis and they showed that the 1.7 and 1.9 millimeter the cutoff is proven, and thus they supported the AJCC recommendation, what the AJCC told. And even the studies, like recent studies now, the Almeida et al. Published in 2020, and another study by Kiran Joshi et al., that is the Rajiv Gandhi Cancer Institute group, they published in 2022 about their patients. They also showed that there was a major prognostic difference in using this minor 2 millimeter cutoff. But for many studies, other like Greenberg et al. And Pirelli et al., they tried to study and they did not support this 2 millimeter threshold. So still there is a lot of heterogeneity. And Arun et al. Did a study in which he showed that a 5 millimeter cutoff is what they found was having a prognostic significance and not 2 millimeter cutoff. So one other like a MCDB database published in 2022 of 7,975 patients, in which 25.4% had minor ENE and 5.2% had macroscopic ENE, and both ENE as such decreased overall survival compared to nodes without ENE. But the addition of chemotherapy to radiation, they said that did not provide any benefit. But this is a retrospective analysis. However, because of the number, we can consider it to be one important paper. Hence, for now, in the AJCC staging, we just we have two categories, and either is considered ENE positive for the definition of pathological nodal staging. And many have told that instead of this microscopic and macroscopic, we should have terms like major and minor, because both microscopic and macroscopic is pathological only, so it can create one doubt. Now coming on to radiological ENE. So what are many studies have shown that what are the findings we can see on radiology, which can suggest that there is extranodal extension. So there can be apparent fat and soft tissue infiltration of local structure like muscle, vein, artery. There can be capsular irregularity, nodal necrosis, intranodal cyst, nodal matting, poorly defined margins, and infiltration of adjacent fat. So these are important terms you should know by describing these nodes on radiology. So what is conglomerated lymph nodes? So it was an old term in which multiple juxtaposed nodes are inseparable from each other. However, the conglomerated term does not emphasize the disappearance of capsule. Hence, we should not use it for extranodal extension. Then comes as matted. So matted requires 3 or more involved lymph nodes. So when there are 2 lymph nodes together with disappearance of the capsule, then it is called as matted. But the most important term which you should use now for radiological extranodal extension is coalescent nodes, in which there is a tumor triangulation through the nodal capsule, which is manifested as extranodal extension. So this is the term which you should use, coalescent nodes. Now there is some grading of the radiological extranodal extension also. So generally it is divided into 3 grades. So grade 1 is the tumor is breaching just the nodal capsule and slightly coming out. But it is confined to your perinodal fat. So you can see ill-defined nodal borders. That is grade 1. Grade 2 is when there is 2 or more nodes which are involved and tumor is coming out. So we can further divide it into 2A and 2B. So 2A is when both the lymph nodes are together, while 2B when they are separate. And grade 3 is when it involves the other structures around, which can be skin, muscle, carotid, and other locally advanced nodal disease. So for few authors have tried to grade this further, like Huang et al. And Mahajan et al. So as I said, Huang et al. Has told the grade 2 into 2A and 2B. So when both the nodes are combined, so it is 2A, and when they are separate nodes which are invading out of the capsule and forming a mass, coalescent mass, it is 2B. And Mahajan et al., he has tried to compare the clinical radiological ENE with pathological ENE, and he has graded them into 1A to grade 4. Now, what is the sensitivity and specificity of radiological ENE or image guided ENE? So, comparing it with pathological ENE, there is a sensitivity of 60 to 80% and specificity of 72 to 96% to detect pathological ENE. So, radiological ENE does have a lot of significance. Now, coming on to the third spectrum of extranodal extension, that is clinical extranodal extension. So, there can be skin involvement, there can be infiltration of your local muscular structures and adjacent structures. So there can be fixation or restricted mobility on palpation. And finally, there can be any local cranial or peripheral nerve dysfunction like involvement of vagus nerve, which can cause vocal cord paralysis, or there can be involvement of the sympathetic cervical chain, which can cause on. So these are the clinical findings you can find on extranodal extension. Now coming on to HPV-related oropharyngeal squamous cell carcinoma. So we all know in the nodal staging of HPV, the extranodal extension is currently not used. This was because of many studies. All these studies have shown that there was no negative prognostic impact on pathological ENE in HPV-associated oropharyngeal squamous cell carcinoma. Hence, the addition of chemotherapy to radiation may not be needed. So, because of these studies, currently there is no extranodal extension. However, so many studies have come, like our own Tata paper also, the Nair, Deepa Madam's paper, then there are so other papers like Pompeli, Michio, all these papers have shown that HPV is important, and it's like external extension in HPV related cancer is important. So this is a meta-analysis recently published in 2022 by Ben Chetrit et al. 18 studies, sorry, 3,603 patients of HPV positive oropharyngeal squamous cell carcinomas, in which 1,521 patients had extranodal extension. The median follow-up period was 49 months, and they showed that both pathological and radiological ENE was associated with decreased overall survival and distant recurrence. So, to summarize, convincing evidence exists that extranodal extension is one of the strongest prognostic factors for both viral related and unrelated head-neck squamous cell carcinoma. Radiological ENE should have a promising role in risk stratification, and evidence suggests that pathological ENE in HPV positive oropharyngeal carcinoma is an independent prognostic factor and should be considered in the future ATCC editions. Now coming on to perineural invasion. So we all know that mainly direct spread, hematogenous, lymphatogenous spreads are the main routes of cancer spread. But you can consider perineural invasion as the fourth method of invasion and metastasis. It was first described in head and neck cancer by Cloyer in 1835. There are multiple diagnostic, prognostic, and therapeutic challenges for the multidisciplinary team in detecting perineural invasion. Squamous cell carcinoma and adenoid cystic carcinoma are generally considered to be the neurotropic tumors, and available evidence now suggests that there is increased risk of locoregional recurrence, but impact on survival is still uncertain. So we should know the important anatomy before going on to perineural invasion. So generally a nerve is made up of three layers. So each individual axon or a nerve filament is surrounded by a layer called as endoneurium, which is surrounded by Schwann cells in your myelin. Then comes when these axons and nerve filaments, they form something called as a fascicle. So there are multiple fascicles in the nerve, and each fascicle is surrounded by a perineum. So these are the fascicles, and the fascicles are surrounded by this perineum. And the complete nerve is then surrounded by your epineum. So how do you define the perineural invasion? So the earliest definition was given by Butsakis in 1985. He just suggested that any tumor cell invasion in, around, and through the nerves is considered as Butsakis. Is perineural invasion, but this is the generalized definition. So subsequently, now the most used definition is given by Liebig et al. He defined it as finding of tumor cells within any of these three layers, perineural, or endoneurium. of the nerve sheath, that is type A, or if the tumor is in close proximity to the nerve and involving more than 33% of its circumference, then it is called as perineural invasion. So he divided it as type A and type B. So this definition is most used. So perineural invasion can be seen in any of these techniques. So you can have the nerve surrounded by the tumor inside the main tumor bulb. So in this pathological slide, then you can see the tumor encircling the nerve. Like if you see, this is the nerve in center, and there is tumor around the nerve within the tumor bulb. Then you can see in this the tumor cells have gone inside the nerve. So the tumor cell can be seen there. And finally, you can see the tumor surrounding at least 33% of the nerve circumference in the lower right bottom corner. So in these four ways, perineural invasion can be seen. So it is a dynamic process which involves mutual tropism between your tumor and nerve. Why this happen? Because that perineural space is an appropriate tumor microenvironment. So there are multiple neurotropic factors released, like brain-derived neurotropic factor, glial cell line-derived neurotropic factor, and NCAM, and your nerve growth factor. And the most important nerves which are involved in head neck squamous cell carcinoma are the trigeminal and your facial. What is the incidence of perineural invasion in head and neck cancer? So it is very like again heterogeneous data because there is a lack of a certain method to now say that perineural invasion is present or not. So in good pathological centers and good pathologists, they show that even the slightest perineural invasion is present, but in other places and where good pathology is not available, which a perineural invasion can be missed. So as you can see, many papers have shown right from 7.5 to 90%. So because of that, the incidence is still not established. Then you have to know two important terms, perineural invasion and perineural spread. So what is perineural invasion? It is microscopic finding of the tumor cells infiltrating the or associated with the small nerves, but it cannot be seen radiographically. So it's mainly on the pathology. And there is perineural spread in which there is presence of gross tumor spread along the nerve, at least in the part distinct from the main tumor mass, and it can be presented with clinical symptoms related to the involved nerve, as well as you can see on radiology. What are the clinical signs of perineural invasion? So 40% are generally asymptomatic, and you do not know whether perineural invasion is present. You just detect it after surgery. If symptoms are there, it can be both sensory and motor. Sensory in the form of pain, paresthesia, numbness, formation of motor denervation weakness. So it generally along where the nerve supplies or the dermatomes, we can see the findings. So if the ophthalmic branch or the maxillary or the mandibular nerve which supplies the various parts of the face, you can see the different sensory weakness. So ophthalmic is generally on the upper one third of the face near your eyelid or the forehead skull. The maxillary is more in the middle part of the face, so the cheek areas and the nose, and the mandibular is lower down near your mandible. Facial nerve weakness will be all your motor weakness of the tongue, the facial muscle because of the chorda tympani, the facial muscles of expression, the platysma. And when you come to the lower cranial nerves, it can be glossopharyngeal and vagus, which can give signs and symptoms of dysphagia, gag reflex, hoarseness. Then spinal accessory weakness of the shoulder and drooping, and hypoglossal nerve, that is paralysis of the tongue muscles. So pathological PNE, how PNI, how it is described. So generally there is location, density, and pattern. In location, the distance to the tumor's edge can be measured in millimeters. So if the value is positive and if it is more than 0.2 millimeters, it is considered as an extratumoral perineural invasion. Then comes intratumoral when the invasion is within the mass. And finally, there is a term as peripheral location when it is between that 0.2 and means within that mass. So that is peripheral location. Then density. So how density is calculated? By the number of perineural invasion foci per tissue per section. So generally it is described as 1 to 3 or more than 3. However, few authors have suggested to grade it as focal, moderate, and extensive. So focal is when only one nerve is involved. Moderate is 2 to 5 nerves, and your extensive is when more present is more than 5. And finally, the patterns can be described such as complete encirclement or incomplete crescent-like encirclement, sandwiching onion skin, partial invasion, and complete and incomplete encirclement are the most prevalent patterns seen. So in pathology, you generally it shows this characteristic onion skin appearance. Then on AE1 and AE3 keratin stains generally positive in this perineural invasion, and IHC of GLUT1 is then highlights that perineural invasion is present. So imaging MRI, as we all know, is the most sensitive and gold standard for perineural invasion. Detection of the extratumoral extension along the large nerves is known as perineural tumor spread. The T1 weighted sequence is the most important sequence in which we see the perineural invasion. And routine T1 weighted and post gadolinium fat saturated MRI sequences are the most useful. So the general signs on MRI we can see for perineural spread are nerve thickening, any widening of the neural foraminas, for example, foramen ovale we see when your inferior alveolar nerve is involved, loss of the fat surrounding the nerve, and finally abdominal enhancement because of the disease. So in this, there is you can see the infraorbital nerve is involved by the tumor of the anterior maxillary sinus. So what are the by seeing the involvement of the nerve, we can predict from where the disease is arising also. So if the nerve involved is maxillary, then the potential tumor sites are from your orbits, ethmoid frontal sinuses. When your maxillary nerve, that is V2 branch is involved, then you can see the areas involved being pterygopalatine fossa, foramen rotundum, or the cavernous sinus. So the disease can be in the maxilla, the palate, the nasopharynx, maxillary sinus. Then the V3, that is mandibular inferior alveolar nerve, is generally, as I said, widening of the foramen ovale. The potential tumor sites being your masticator space or any mandibular pathology. Then the seventh nerve or the intratemporal component can be involved in disease of parotid gland or temporal bone. And median nerve also can be seen enlarged in diseases of nasopharynx or the lacrimal gland. So, what is the prognostic significance of perineural invasion? So, multiple studies have said that it is a significant prognostic factor, with many different studies showing different outcomes, decrease overall survival, decrease disease-specific survival, recurrence rates, local, distant, and the presence of metastasis. So hence, for now, when do we consider radiation therapy for perineural invasion? So when there is cutaneous squamous cell carcinoma of the head and neck with extensive microscopic perineural invasion, aggressive salivary duct carcinomas like adenoid cystic or salivary duct, mucosal squamous cell carcinomas with currently extensive microscopic PNI, and any primary tumor demonstrating clinical or radiographic perineural spread. However, if a perineural invasion is the only sole prognostic factor and no other factor is present, currently there are not much evidence to suggest that it is radiation is to be considered for adjuvant treatment. However, there is a trial being done by Tata, which is called as adjuvant radiotherapy in early stage the tongue cancer. So that's a ALESH trial. So that might suggest in future whether perineural invasion is a factor for adjuvant radiation alone or not. So a few recent advances in perineural invasion. So there is a molecule called as odoplanin. So this is a study done in 83 specimens. So what they suggested, that if we do a pre-operative molecular marker podoplanin in our incisional biopsy, they suggested that the podoplanin positivity showed a high sensitivity in predicting PNI in the surgical specimen subsequently. So, in 93.5% of the the biopsies in which they found podoplanin positive, there was PNI later after surgery. So this is one of the recent advances seen. And a few more studies have suggested that instead of only invasion, if we calculate the nerve tumor distance, so if there is a nerve uh, and surrounding that there's tumor seen, but we generally we would not call it as perineal invasion, but the closer the nerve tumor distance, and if the size of a nerve as such is larger, both of these have shown that there is poorer prognosis seen in these patients. So maybe future we can consider. So to summarize, perineural spread is commonly described in adenoid cystic carcinoma, but may be seen in variety of diseases of the head and neck. The MR imaging is the modality of choice because of its multiplanar capability and superior soft tissue contrast. With knowledge of our cranial nerve anatomy, potential pathways of perineural spread can be predicted on the basis of primary tumor location. And PNI is now a widely accepted clinical and histological pathological feature that is frequently associated with aggressive disease and poor prognosis. Thank you.